women are great maskers or great minimizers, right? And I think a lot of people make the mistake of interpreting how functional things are on the outside
Yeah.
with how well people are doing on the inside. But women
Yes,
will
yes.
sacrifice anything to keep the household running.
Hi, I'm Dr. Lori Stevick-Rust. 40 years of sitting with people through their hardest moments has taught me one thing. Our power lives in our courage to be real. This is where we stop pretending and we find our way back to ourselves. I'm glad you're here. Now pull up a chair. This is Becoming Real. Our guest today is Dr. Lulu Zhao. She's an associate professor of reproductive biology and obstetrics and gynecology at Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. And she's the co-director of women's behavioral health at the Cleveland Clinic. After completing her residency in obstetrics and gynecology at University Hospital's Cleveland Medical Center, Dr. Zhao completed a fellowship in women's mental health at the University of Michigan, as well as board certification in addiction medicine. Dr. Zhao specializes in mood disorders during key reproductive transitions such as puberty, pregnancy, and menopause. With the current trial being in the news, it has renewed the conversation about postpartum mental health issues from depression, anxiety, intrusive thoughts to psychosis. The goal of this podcast is to clear up clinical information for both women who are out there struggling and for the partners and support people who love them. Thank you so much for joining us today. I think we have hours and hours to talk about this really important whole range of issues. But before we get into talking about women's hormones and mental health and all what happens that changes through pregnancy and menopause, I mean, we are complex creatures for sure. But before we get into all the good stuff that we need to be talking about and the important stuff, tell me a little bit about what brought you to this intersection of mental health, psychiatric care, addiction, and you're also an OBGYN. You are a psychologist's dream as a referral, looking for somebody that we can bring on our collaborative team to help women. So how in the world did you get yourself into this spot?
It's true that I have a pretty unique job, and I'm so lucky to have that job, Lori. So for me, I've always had an interest in psychiatry, and really I think it came back to why do people do things, right? When I was in college, I was a history of medicine major. I was very interested in knowing how do we get to the place we are and why do people do the things they do? So I've always liked psychiatry. But I really loved working with women. So when I was in med school, I was debating between psychiatry and OBGYN. I ultimately went with OBGYN because I just love working with women. But during my residency, I did, somebody in my family did become diagnosed with a serious mental illness. And I think that just pushed me to think about all the ways that women with mental health diagnoses may have unmet needs within OBGYN, right? There was, this was back in the 2000s. People didn't know whether people could stay on meds. They didn't know whether or not they could take care of babies, you know, if you had schizophrenia, for example. So I just realized that there was this huge unmet need there, and I felt like I could do something about it. And I was lucky enough to be supported by mentors that said, hey, yeah, like you should pursue this. And they really helped set me off on my career path.
Oh, I love that. I share your frustration thinking we put particularly women in buckets. So that's your GYN problem. Now go see the psychiatrist or the psychologist, or, you know, that's a primary care doctor's issue. And yet, you know, as a health psychologist, I know we're holistic beings. It's very hard to parse that out. Even though I know we need specialists, we need to have a bigger lens to say, here's somebody who can collectively and comprehensively look at you from all angles. So tell us a little bit about your clinic and the kind of work that you guys do with your team.
Absolutely. So I'm part of a service line at Cleveland Clinic called the Women's Behavioral Health Team. And we specialize in what's called reproductive psychiatry, which is psychiatry that occurs during reproductive time points. So really times where your hormones are changing or fluctuating, and we expect some of those changes to impact the way that you feel. And so what we do is we see women who are experiencing things like postpartum depression, postpartum anxiety, PMDD, which is premenstrual dysphoric syndrome. We look at people who have perimenopausal depression, and we try and help them understand where the hormones come into play, where the brain comes into play, where life situations come in play, right? Because when you think about these transitions, becoming an adult, becoming a parent, becoming someone who's entering the midlife, all those changes are happening at once. And it can be very confusing as to, what's causing what. So we really try and take a holistic view and say, okay, this is probably because your hormones have changed, right? That's the trigger. But now in this vulnerable state, you have a parent who's sick, right? You're when entering the midlife, your mother is not doing well. Your children maybe aren't launching the way you think they are. You may have health diagnoses that are new for the first time in your life. Of course, you're totally stressed out. And how did those factors combine then to, for some women, cause a psychiatric diagnosis, right? For the first time in your life, you have severe anxiety. You've never had that before. And then we kind of help them figure out what do you need to do to kind of help yourself feel normal again, right? Your life isn't going to be the way it was before because you're going through a transition, but how can you go through that period with the most grace and the most strength?
Yeah, I love all of that because certainly I know in my practice, sometimes the hardest thing for women is to acknowledge that this is happening to them. And I think, you talk about the history of medicine. I think about the history of messages that women have had over the years, which is it's your hormones. Almost
Mm-hmm.
like a,
Like it's just it. That's
women
just being a
before you,
woman. You're gonna go
yeah,
crazy,
right.
you know?
Women before you have done it or even pregnancy, like, so you're going to be sleep deprived. All new mothers are. There's
Right.
so much of a, just buck up and get through this that when
Like,
women go, I can't. So that I know there's a lot going on in the news right now with
yes.
conversations happening through the trial about postpartum psychosis, postpartum
Mm-hmm.
depression. But I also think in addition to that, there are these intrusive thoughts that many women talk about to me, but
Mm-hmm.
not to their families, not to even their spouses sometimes, because it feels so scary. Like I don't want anybody to think I'm crazy and then take my children so they silently suffer. And I am confident that there are women listening to this who are saying, oh my God, yes, that was me, or that's currently me. So let's talk a little bit about that whole range of our hormones dropping during pregnancy, immediately after delivery, postpartum anxiety, OCD, intrusive thoughts, and psychosis. Like that's a whole continuum. Let's talk a little bit about what that looks like. And for women who are listening, what they should be talking about to themselves and to the people that love them.
Mm-hmm. Yeah, it's definitely a spectrum of how women can present. But I always think about the baseline reason is sort of the same. Like we all have our brains. Our brains can only handle so much based on your genetic vulnerability, your overall health, your temperament, things going in your life. And sometimes people from hormonal changes, from life stressors, sleep deprivation, it reaches that tipping point, right? Where your brain says, I can't really handle this anymore. And then you become symptomatic. How symptomatic you become then depends on those same factors, your resiliency, protective factors. Do you have family who can help you out? You're probably not going to be as severe, right? Or are you somebody who's had just recurrent episodes, severe mood episodes your entire life? Yes, you're probably going to suffer a little bit more. And so I think one nice thing about the trial that's come out is there's been much more conversation about what we need to support women, because you're right. For a long time, women were just told to buck up. You signed on for this. You signed up to be a mom. What did you expect? Of course, you'll be sleep deprived. And you can both say, yes, this is an expected part of parenthood and say, but I shouldn't have to be doing this alone, right? It takes a village. So the women I see really do run the full gamut of some people actually don't have they think they might, but they actually just have a situational like anxiety or depression. So they don't actually meet criteria for major depression or, generalized anxiety. They've never had issues before, but something happened that is situationally really anxiety provoking, like their child was just diagnosed with a heart condition or something postnatally that they weren't expecting. I think any parent would feel really, really scared and anxious if you have a diagnosis like that. So sometimes all you need is somebody who can support you through this time, right? Because once the surgery is done, once you know your child is healthy, the anxiety goes away. Or same thing, like once you go back to work and you realize that your boss is able to be flexible with your new life, your anxiety goes away. So I think sometimes it's a situational, temporary type of thing, and we just have to build up support. Sometimes, even though it is mostly a situational stressor, your brain has taken that situational stressor and it's kind of run away with it,
Yeah.
right?
Yeah.
So yes, the situation will end eventually, but in the interim, you can't sleep, you can't focus, you can't think, you're not enjoying things. It's been going on for a couple of weeks now. Yes, at that point, you meet diagnostic criteria for a major depressive episode or, an anxiety disorder, and that should be treated right away with, again, you still need support. I think of it as like a building block. Everyone needs support. Next step, probably everyone needs psychotherapy, to kind of go
Right.
through what's going on in
Right.
their life. And then on top of that, then you can talk about medicines. We need to check for other things that could be going on in your body. People can get postpartum thyroiditis and have anxiety related to that. So I think of it as looking for and building on what patients might need to feel better. By the time women get to me at Women's Behavioral Health, a lot of times symptoms are severe enough that they need medicine. And the medicine is not usually something that they'll need for the rest of their life. A lot of women have their first ever mood episode in the postpartum, right? They're not somebody who necessarily has lived with depression or anxiety their whole life. A lot of people do, but a lot of them this is de novo first time. And so for them, I think starting medicine oftentimes feels really scary. You hear all these things about medicine in social media, how they can be, bad for your brain. What if you get addicted to it? Medication side effects. Yes, side effects can happen. Yes, some people do need to be on medications for a long time, but I also think there's so much misinformation out there that is scaring women away from treatment that can substantially improve the quality of their lives. So the way I explain to women is, listen, a bunch of triggers just happened in your brain that caused your brain to say, oh my gosh, I can't handle this right now.
Mhm.
And it's starting to think in a really negative way reflexively, right? That's your normal right now. Every time you see your kid go out of the house, you wonder if they're safe. And what if somebody snatches them on the street, right? That's not how you used to think.
Mhm.
And now it's stuck kind of thinking that way. You might need, again, support, psychotherapy, and medicine to help your brain get back to a more objective, neutral, and maybe even positive way of thinking. And you just need to take the medicine or your treatment, as I really think, consider the whole treatment. You need to do your treatment long enough that your brain unlearns those negative thought patterns and you learn kind of coping skills to redirect yourself away from unnecessarily negative thoughts. And then at that point, you can decide. Some people will say, okay, yeah, you're right. Like, this stressor I went through, my baby had bottle refusal. They weren't gaining weight. I had to go back to work. It was really stressful. That stressor is gone. You've learned more coping skills. You've done your CBT, which is cognitive behavioral therapy. You've taken your medicine so that you're not having a panic attack every time you have to go to work. It's been 6 months of feeling great. Yeah, we can talk about coming off.
Mhm.
Some women will say, you know what? Now that I've been on medicine, I realize I've had anxiety my whole life.
Right.
And this is the best I've ever felt.
Yep.
And they may choose not to go off the medicine, but it's very individualized and you
Mhm.
always have a choice. So I really want to emphasize that women sometimes are scared away from using treatment when in fact, treatment is going to really make them feel more like themselves, not less like themselves. And it's going to really help them achieve the kind of life that they want to have.
Yeah. There are situational factors
Mhm.
coming often at the worst time. And,
Mhm.
with my patients, I talk about that stacking effect. It's like if there were just two things, you might be able to manage this way. You
Yep.
put that third thing on, it's the tipping point.
Yep.
So, one of the things that I find, again, with my own patients is they're not talking a lot to their GYN about hormones. And
Mhm.
so I thought maybe that's an important thing for us to
Yeah.
talk about today. Because what I find is when I say, well, did you have that conversation with your GYN? You're only 2 months postpartum, or you're in the middle of
Mhm.
your pregnancy, and these are experiences. And part of it is what you've acknowledged, which is a feeling of sort of shame, like, I don't want to say, because they
Mhm.
see a million women coming into their office who are doing
Yeah.
great, and I don't want to be that one, or whatever version of that.
Mhm.
But I think the way that you're framing this is the way that I think women need to hear this, which is about what's happening to your brain, that this isn't about your character or you're
Mm-hmm.
weak or other women cope better, that this is a brain function, and hormones play such a
Mm-hmm.
strong role. And I don't think we give enough
Mm-hmm.
awareness or conversation about it. So let's
Mm-hmm.
start with that, because there's a lot of
Yeah.
conversation about progesterone, for example, dropping so rapidly,
Mm-hmm.
right? At postpartum periods of time. And what does that do to a body?
Mm-hmm.
And we don't equip women to understand that. So,
Yeah, absolutely. So, our sex hormones, which, are made by our ovaries, so predominant ones are your estrogen, progesterone, testosterone. They, especially estrogen, progesterone, also play a role in the brain. They're not just there to help us get pregnant and release an egg. And that makes a lot of sense evolutionarily because it takes a lot to create a child, right? You have
mhm,
to want to have sex, want to be with a partner, be willing to care about other people. So it makes sense that sex hormones have to have a role in the brain because if you don't have the brain part, you're not going to
right,
be a great parent, right?
right.
So most of us, actually, like 80% of people have some degree of sensitivity when those sex hormones go up and down, right? That's what we call PMS. So about 60 to 80% of people will have PMS symptoms before their periods, and that could be anything from physical symptoms like breast tenderness to mood symptoms like I don't really feel like doing much today or I'm a little more irritable. And then about 20% of women, and some people you would argue if you want to be really strict with their criteria, 5% of women have very severe reactions to when your sex hormones are fluctuating. So I would say probably if you're talking about like the most severe categories like PMDD, which is a condition where your mood deteriorates so much before your periods that you can become things like suicidal, that's probably like 2 to 5% of women. And so thinking about the fact that there's this vulnerability in our
Mhm,
mood when we have hormones that are changing, it makes sense that reproductive transition periods, like that postpartum period where there's a huge drop in progesterone once the placenta comes out, can make women feel different mood wise, right?
mhm,
That's also why, just like PMS, 60 to 80% of women have the postpartum baby blues for the first 2 weeks, right? When you're just super emotionally labile. You're watching a TV commercial with kids and you just start crying for no reason, right? It's kind of like the PMS of postpartum is what I think about it.
mhm.
But then some women won't have just the baby blues. They will continue to have really ongoing, more severe symptoms that we would consider them postpartum depression or anxiety. So when you go to the GYN's office, I mean, to some extent, I'm an OBGYN. We all know these hormonal changes are happening. Um, but sometimes I think it gets dismissed or at least not really addressed because it feels like there's nothing you can do about it, like especially
Right.
in pregnancy. I can't control I can't make the hormones not go up and down. But just because I can't control it doesn't mean I shouldn't be thinking about it.
Mhm,
So for women that I know have a history of depression and they're seeing me during their pregnancy and they're fine at that moment, I do have that conversation with them about, hey, how do you think things are going to feel postpartum? Have you had postpartum depression before? Have you had really bad PMS or PMDD before? What do you want to do if postpartum? You don't have just the baby blues, but you actually get depressed. And what would that look like? I think those are the kind of conversations we can have, even though we can't fix the hormonal part. And then I think this is probably also really in the air right now is perimenopause and menopause. Unlike pregnancy, we actually can do something to adjust the
right,
hormonal transition
right.
or at least to smooth it out. We can't stop the process, but we can do a lot to smooth out that hormonal transition for women.
Mhm,
And so it's a really great time, I think, in medicine to be having conversations at your annual Well Woman Check. If you're a woman, I would say in your 40s or beyond, I always ask, I think everyone does, like, what are your periods like? But then
mhm,
beyond that, what have you noticed changing this year? Are there things that are changing that are concerning you? And in the beginning, it will be subtle stuff like I'm more tired, I can't sleep as well, I'm more irritable, my hair is thinning, before the period even changes. But that's a good time to say, well, it could be XYZ. It could also be your hormones. This is what we'd be watching for. And if we do conclude after observation that this is likely part of your hormonal transition, here's what we can do about it. right? And women are dying for those conversations.
Oh, 100%. As you're saying that, I'm thinking, gosh, I wonder how many women have that kind of relationship with their GYN. Now, again, you're unique and your
Yeah.
clinic's unique because you're thinking about it through both lenses. But,
Mm-hmm.
to be fair, and this isn't beating up on GYNs, but, they got a 15-minute window
Right.
and they're not, if you're not complaining or you're not directing
Mm-hmm.
the conversation to a certain thing
Yes.
that's important to you, it's unlikely to be addressed. So,
Yeah.
I could imagine a woman hearing you say, you've had depression before.
Mm-hmm.
We're going to watch this. Let's see what we're thinking about postpartum. You've now opened up a conversation that gives that woman a doorway to walk through, that the next time she sees you is to say, remember when you talked about that?
Yeah.
Then now it's happening.
Yes.
Versus never opening the door. I think there's a percentage of women who say to me, that just feels like a strange thing. Like I was in and out. We had to talk about bleeding. We had to talk about, so many important things that I wasn't going to talk about, these intrusive thoughts that just keep coming in and keeps me up at night because, I'm sleep deprived and all sleep deprived women. So they make assumptions.
Yeah.
What would you say to women in terms of things that they should be prompting their professional with conversation? And then do you also talk to the colleagues of yours that are the generalists, raising awareness that just because women don't bring it up doesn't mean that it's not on their mind?
Absolutely. It's tough. I was, for many years, I had a quote unquote regular OBGYN job, where you're training through 25 to 30 patients a day and double booked 15-minute appointments. And let's be honest, if you wanted to do a really good job, you ran behind, and because it's just not possible to have those conversations. So that is the unfortunate reality of corporate healthcare today. I think most practitioners are not happy with this system, but they also don't want to, if you reduce your schedule, that's less patients that can be seen. So it's a really delicate balance. So to some extent in this environment, you need a multi-pronged approach. Yes, clinicians need to be aware that an annual checkup is meant to be preventative. It's like a well child visit. You don't want to just bring your baby to the pediatrician. They're like, yep, no moles. They're not throwing up. Great, bye. Like you want anticipatory guidance, right? Like here's what's going to happen in the next month with your 4-month-old. The same thing should happen in OBGYN. If you, again, our anticipatory guidance is like probably in 5-year chunks, but if you're coming in for a well woman visit, you're 40 years old, I should be talking to you about, and just, so this is what kind of screenings start now. These are some symptoms to watch out for. And it can be brief. It can just be 1 to 2 minutes of talking about what can happen. And you can do that while you're doing the physical exam. We are very good at multitasking in the field. So I do encourage my colleagues to do stuff like that. So I think that's on the clinician side. On the patient side, again, because this is the reality we live in, it is helpful to come in prepared with questions or with requests, So, and it could be something as simple as, hey, what should I be looking out for in this next year? What kind of anticipatory guidance can you give me? Or I'm having these symptoms. Could they reflect menopause, or do I need any kind of workup? Right. So I think if you have concerns, write it down, because in the moment it can feel really difficult to recall things or even awkward to bring things up. But if you write it down, you could just say to your doctor, hey, I just came in with a little list. Do you mind if I go over this with you real quick? You want to say this like kind of at the beginning of the appointment. And they may say to you, hey, that's a long conversation. Come back for another visit.
Yeah.
That's okay. I mean, that's acceptable. That's being realistic. But at least then you've opened the door to actually have your concerns be addressed. Certain things like intrusive thoughts, you are correct. People do not disclose intrusive thoughts readily because there's a lot of shame about them. There's also a lot of fear about that. If I tell people I'm having these thoughts, then they're going to think I'm crazy. They might call my husband, tell him I'm crazy, commit me, or they might just think I'm weird, And so things like that, we don't routinely ask about intrusive thoughts in OBGYN annuals. That's not really part of the visit. And I feel like what usually women say is they don't say they have intrusive thoughts. They just say, I haven't been feeling like myself. I'm feeling anxious these days. I have a lot of worries. And that to you as the clinician should be a cue that people usually disclose one level less than what they're actually feeling.
100%. As you were saying that, I was thinking, and then the next layer when I say or
Yeah.
and they know that, I'm asking,
Yeah.
let's go to that next level, because the next level is more like, I have these fleeting weird thoughts of like
Mm-hmm.
dropping my baby, or fleeting
Mm-hmm.
thoughts of like forgetting them on the roof of the car, or,
Yep.
the things that we know is
Are
what
bizarre.
sits underneath a lot of anxiety, but
Mm-hmm.
sounds so
Crazy to say out
crazy.
loud. Yep.
Right.
I've had
Right.
women who just have images of throwing their babies down the stair, just head over
Yes.
heels, tumbling down, and they just
Yes.
scoot down the stairs on their butt,
Yes.
So,
Yes. Yes.
so as a clinician, you have to be aware that when people bring up things that are a little bit taboo, like their
Mhm.
sexual dysfunction, their mood, what they're experiencing is probably like 20% more than what they're telling you. And that's a cue for you to refer them onwards to more help if you feel like that's not something you personally manage.
Yeah. Yeah. So, again, there's a lot of conversation right now in the media, which I think
Mm-hmm.
the upside of that is we're talking again about postpartum depression, postpartum anxiety,
Mm-hmm.
postpartum OCD, postpartum psychosis, because there is such a change for many women from the mild
Mm-hmm.
to all,
Yep.
upwards to something very significant. But, one of the stats that always has struck me is that, 75% of women with perinatal mental health, so
Mm-hmm.
going through the process right before delivery, never get treated.
That's right.
And the most significant deaths occur from people
Mm-hmm.
who commit suicide in that
That's right.
period of time. So while we can talk about what is normal and we need to make sure we stay on top of it, there's
Mm-hmm.
also women who are really suffering
Yep.
that, 75% to not
That's
get
a lot.
treated is a huge number. So I guess my question then always falls back to, what do we as clinicians need to do better, but also the people who love them, who are the firsthand
Mm-hmm.
people. There are a lot of partners out there, I'm sure, who
Yeah.
might be listening.
Yeah.
And many will say, I thought she was just having trouble because we're not sleeping. It's
Mm-hmm.
the baby's up all night. Or I should have seen that, or I should have known
Mm-hmm.
that. How can we equip, messaging for partners? Because
Mm-hmm.
I often look at this and think, somebody might watch this podcast and go, oh, this is on women's mental health and
Mm-hmm.
postpartum. I'm a guy. It's got nothing to do with me. And
Right.
I say you should be in the front row,
That's right.
because if you love a woman who's going through these things, whether it's your
Yeah.
partner, your sister, you need to be lockstep with what's happening to them as
Absolutely.
well.
Absolutely. So women are great maskers or great minimizers, right? And I think a lot of people make the mistake of interpreting how functional things are on the outside
Yeah.
with how well people are doing on the inside. But women
Yes.
will
Yes.
sacrifice anything to keep the household running. I mean, they will go without sleep, they will go without eating, and if all you're looking at is the fact that, oh yeah, she's still taking the kids to activities and she's still throwing the birthday party and she's still getting meals on the table, she must be fine. You're wrong. It's very important for partners and family members to actually ask the woman how she's doing and how they can help, right?
Mhm.
Because she may tell you, yeah, I mean, this I hear all the time from my moms. I mean, I got all those things done because I have to. But then at night, when everyone's snoring, that's
Mhm.
when I'm thinking. That's when my stomach is upset. I can't
Yes.
eat. And so you really have to check in and say, hey, thank you so much for doing so much for our family. But how are you doing? Is it too much for you? Where can I help? You have to
Mhm.
ask. And here's another cue. If you have a partner who just blows up at you every few days or weeks, they're
Mhm.
not doing okay. They're just holding it in and then it's boiling up
Yeah.
and then so if you have a
Mhm.
partner who seems to inexplicably just be mad at you, they have unmet needs and you need to
Mhm.
figure out where you can step in.
Yeah.
Men I don't think are bad, but I think some of them are oblivious and
Yes.
they were
Yes.
trained by society to be that
Yes.
way.
Yes.
I mean, I have men who are asking to go golfing when their wife can't even get into a doctor's appointment to do an allergy test. Like
Mhm.
if your wife is saying, hey, I'm having trouble fitting in this thing, you need to be like, okay, where can I give a little bit,
Mhm.
And yes, men are perfectly capable of watching children,
Yes. Yes. Yeah.
They
And
are.
and even the good ones who
Yes,
are
even the good
listening, who
ones.
say, I really want, like I
Mhm,
do the laundry and I do the
mhm.
grocery shopping and
Yep.
I'm helping. I think the next level of help, when I hear partners saying, she went to the doctor, it's like, well, was
Well,
there an
go to the
opportunity
doctor.
for you to go with
Yeah,
her? Because
go
I
with her.
think hearing what a doctor is saying, when a doctor is saying, this is what's happening to your progesterone. This is what I hear from
Mhm,
women with intrusive thoughts. How is
mhm.
that happening to you? Sometimes a third party
Really
conversation
helps.
sinks in differently. So,
Yeah.
I recognize that there are limitations, and we're privileged when we have jobs that will say,
Mhm.
hey, can I go to the doctor's appointment with my wife? I
Yes.
recognize that. But
Yes.
if the feeling is, well, she didn't ask and it seemed okay,
Right.
I guess the moral of the story, I hope, from this podcast for the men listening is maybe she doesn't even know what to ask for.
Mhm.
This has
Yeah.
to be a collaborative, partnering,
Yeah.
navigating. Because when I hear stories of women who suffer so hard and
Mhm.
people go, yeah, I knew it, but what could I do? It's like, well, what you could do is a whole range of things, and
Right.
you need to understand that.
Right. Because a lot of times, women will say, I can't ask my husband to do that. He works so hard already. I don't
Mhm,
want to burden him. He already helps me so much. But if the partner had been there, they might say, but it's okay, babe. Like, I can
mhm.
do more. I can support you better. So just recognize when women have anxiety, especially, they're not going to necessarily ask you for help, or they're not going to be comfortable accepting help because their anxiety is making them think that only they can do it. Right. And
Right.
that's where you have to be the other voice to say, listen, babe, I may not load the dishwasher as well as you, but
Mhm.
I can wash the dishes,
Yeah, yeah.
and
I would love for a man to be able, a partner to be able to pass a postpartum class 101 to say,
right.
because, without understanding when
Yeah.
this placenta comes out, that progesterone's dropping
Mhm.
and this is what's going to happen.
Yeah.
Even men who are in the delivery room, who are
Hmm.
amazing,
Yeah.
partners,
They just don't
that's
know.
not part of what we're teaching them because a lot of women don't
Absolutely.
even know it. So
Yeah.
I wish there was like and maybe that's part of what this
Yeah.
podcast will do is it's
Hmm.
a postpartum 101 for everybody, women,
Right.
the parents, the
Hmm.
siblings, everybody to
Yeah.
understand what's happening.
Right. And it's way beyond just when the placenta, I mean, yes, that's a huge moment is when you
Yes.
first deliver, but also just think about the whole first year postpartum. It is a prolonged period of chronic sleep deprivation. You might
Hmm.
be hormonally suppressed the whole time, right? You're breastfeeding, you may not be cycling. I have some women who just
Mm.
don't feel like themselves as long as they're hormonally suppressed. It's kind of like being in perimenopause. For some people, a low estrogen state just makes them feel really blah, right? And so you're feeling that way until you stop breastfeeding, or when your cycles start to come back and you had PMS or PMDD before. Now your hormones are changing again when you had 9, 10 months of stable hormones. So there's so
Hmm.
many transitions that happen in that first year that
Yeah.
can make women feel off. And we need support. I mean,
Hmm.
really, I think until 2 years postpartum is when things start to get back to normal.
Well, that's interesting because I think I read something, and you can correct me here, but
Hmm.
most women go back 6 weeks and then,
Yeah.
but then it's sort of we're done with you.
Yeah.
So they're not going in. Clinicians are not screening to check in to
Hmm.
see what are you looking like 6 months down the road or a year down the
Hmm.
road. Do you think that that's something that we should be moving towards in medicine, that we treat
Yeah.
this birthing process as the medical thing that it is, as opposed
Hmm.
to, yeah, women's had babies for generations?
Right. So the 6 week drop off cliff comes from insurance, right? Insurance global payments end at 6 weeks postpartum. And therefore, you don't get a 12-week postpartum checkup, right? Because
Mhm.
it wouldn't be paid for. And it's a whole different conversation about how we shouldn't let insurance dictate our care, but it does all the time.
Yes.
So at the Cleveland Clinic, and I think at a lot of places, what we do is you do your 2 week. So we do a 2 week and 6 week checkup postpartum. And then we tell you to come back for an annual within 3 months, which I think is an acceptable way to kind of check in. Because, when you think about 4 months postpartum, there's a lot of changes that have happened then, right?
Mhm.
You've gone back to work, your hormones may have shifted, the baby's a little bit older. Those things can either positively or negatively impact your mood. And it's important to do a check in at that point.
Mhm.
And then if you do have symptoms at that point, say you're like, you know what, I realize that 10 weeks postpartum when I had to go back to work, that's when my anxiety really amped up. Then you can refer people onwards to care or you can follow up with them yourself. But it,
Mhm.
it is very critically important that when women are postpartum, they ask for that annual visit to be scheduled.
Yeah. Good advice there. So let's do a quick step into care options because
Hmm.
um, you made the comment earlier of we're not going to change hormones. We know that. During the
They're
maybe
going to
in
happen.
menopause,
Yeah.
because that'll be my next conversation
Yeah.
coming up with another guest because I'm sitting in that space and there's a lot of
Right.
questions for me. But, when we talk about during pregnancy and people who
Mhm.
have depression, I know a lot of my patients will say, I have to come off of this. We're trying to get pregnant. I
Mhm.
don't want to take anything through pregnancy. And they get really stuck in a very
Yeah.
bad place. So, can you talk a little bit about what are safe options for women who might say, I have depression or anxiety and I'm entering
Yep.
pregnancy, and then postpartum as well, particularly if they're breastfeeding?
Absolutely. So the general principle in reproductive psychiatry is to use the lowest effective dose of a medication that will work for you. And so oftentimes, we think about starting with the SSRIs, which are the selective serotonin reuptake inhibitors. These are medicines that affect our serotonin pathway in the brain, which is primarily responsible for higher order thinking and emotional regulation. So these are medications like sertraline, also known as Zoloft, fluoxetine, also known as Prozac, escitalopram, Lexapro, and they're very commonly used for both anxiety and depression, and they work very well. And if you've never been on medicine before, oftentimes we'll start you on sertraline, which is Zoloft, because it's one of the best studied medications in pregnancy. It has a
Mhm.
very favorable safety profile. But if you've been on Zoloft before and it didn't work for you and you actually did better on fluoxetine, it's probably better that you stay on the medicine that works for you, because if you take a medicine that doesn't work for you, you've exposed the baby with absolutely no benefit.
Mhm.
So, the first question I always ask in my clinic, which again, I'm privileged, I have 60-minute appointments, is to go through a full psychiatric history. What are your
Mhm.
diagnoses? What medicines have you tried? How did you respond to those medicines? What are you most recently on and do you feel most comfortable with? So we figure out what medicine you should be on. Again, SSRIs are going to be the most commonly used class because they don't seem to cause birth defects well above the population baseline. They don't seem to make your baby small. They don't seem to cause preeclampsia, diabetes. They don't really cause you to go into preterm birth or anything like that, or increase your C-section rate. And really, the main risk of using them is just, these medicines cross the placenta, just like they calm you down, they can calm the baby down in utero. And then once you deliver and the baby no longer has access to your medications because you cut the umbilical cord, yeah, they might feel a little bit like, hey, where did my SSRI go?
Mhm.
And for a week or two, they might just be a little bit more fussy. But this is not an addiction. They are going to come through that transition period with just supportive care, meaning you cuddle them, you keep the lights low, you feed them on demand, and then they should be fine. They're
Mhm.
not gonna have long-term behavioral issues. They're not gonna get autism. So,
Mhm. Thank you for that.
that's the most common class that I use.
Mhm.
Um, then the next class that some people will need will be the mood stabilizers, right? So some women have bipolar disorder or they tend to just be really um, volatile with their moods and they need a mood stabilizer. And so
Mhm.
these would be medications like the anti-epileptics, so lamotrigine or lamictal. It could be things like the atypical antipsychotics, so medications like aripiprazole or Abilify, or it could be even something like lithium, which
Mhm.
is kind of one of the most effective medications for women who tend to be manic. And it is really important if you have bipolar disorder to remain treated during pregnancy because women with bipolar disorder are at the most risk of developing postpartum psychosis, right? And that is a severe medical emergency. And trust me, you do not want to get it.
Mhm.
So,
Mhm.
and bipolars oftentimes, especially manic states where you're really not acting like yourself,
Mhm.
tend to be triggered by sleep deprivation, which is basically universal
Yes.
postpartum.
Right.
So if you have bipolar disorder, that needs to remain treated.
Mhm.
And there are minor risks to each of those medications, but honestly, overall, very favorable profiles. Again, most women are worried that it will cause a birth defect, cause the baby to not grow well in the uterus, or have a long term neurodevelopmental problem. And for the most part, those medications don't cause those things. So they require some monitoring. They usually require you to increase the dose as you get further along. In fact, most medications require increasing doses as you get to the third trimester because your body clears out medicine faster. But you need to be at a medication dose that keeps you stable because if you stop medication, even if you're feeling good when you were stopping them, the studies will indicate that 50 to 70% of people will have their mood symptoms come back. And
Mm.
that is not good for you
No.
or for the baby.
Right. Gosh, there's so much. We could probably go on forever here, but let me ask you in closing, is there
Mhm.
a particular myth that you think not only women, but their
Mm.
partners, the assumptions that
Mhm.
they make that you think, let's clear that myth right out the door now and leave women who are
Yeah.
listening and their partners, whether they're in pregnancy
Mhm.
or postpartum, um,
Yeah. Oh gosh,
that
there's
they
so
need to
many
be able,
myths.
yeah, I was going to
Yeah.
say that they might need to be able to walk away with and go,
Yeah.
okay, so that's not true. What should we be doing?
Yeah. Wow. So many myths. I guess one myth that I think is really important to say, especially in light of everything that's happening in the media, is that asking for help and telling people that you're not feeling well is not likely to cause you to be institutionalized or have your child taken away from you. I really think that is a driving fear for people who
Yes.
have the most severe symptoms, the
Yes.
people who need the most help.
Hmm.
They know they're really sick and they're really scared if they say something,
Hmm.
then they'll lose their child or their family.
Hmm.
And so sad because actually not addressing those symptoms is exactly what is going to be most likely to cause you to get so sick that you have to be put in a hospital
Hmm.
or to damage your relationship with your family. And that, again, even if they're not removed from you, when you're severely depressed, you're
Right.
not having a relationship with your
Right.
family. So,
Right.
the earlier you ask for help, the more you ask for help, the more likely you are to be successfully treated. And therefore, have the outcomes you want to have. So please don't
Yeah.
let that fear stop you from
Mhm.
disclosing because you're just kind of hurting yourself. I
Yeah.
think that's definitely one message. I guess related to that too is that there are treatment options. A
Mhm.
lot of people still believe that when you are pregnant, it's not safe to,
Mhm.
take medicines, or they're not aware that there is psychotherapy that can be really effective, that can be done during pregnancy. And they are not giving themselves all the tools that they could
Mhm.
be using to feel well.
Mhm. Or holding back. I have women who will say, because of my bipolar, I know I can't have children.
Oh,
So,
yeah.
there's always
Mhm.
that part of, but have you talked about there are ways that this
Mhm.
can be managed
Yep.
without putting the baby or you at risk. So
Absolutely.
I love the information because I think the more information, the better equipped we are first as clinicians to be able to help the patients that come through our door,
Mhm.
but also for people who love them. So for me,
Mhm.
I come back to echoing. I hope that there are partners who are listening to this today. The feeling of you need to understand women's biology. You need to understand what's happening during pregnancy and postpartum because you're in this together.
That's right.
And I think then everybody there's a safety net built in when you have
Mhm.
your collaborative supportive team around you who are educated to understand what's happening as opposed to
Yeah.
well, this
Let's
is
just
what
wing
happens to all
it.
women. Yeah, this
Yeah.
is what happens to all women. So
Yeah.
is there
Absolutely.
this has been great, and I am confident that there will be a lot of people who benefit from this, and I certainly in the show notes will include how to get a hold of you,
Great.
information about you, so anybody who's listening who needs to or it's important for them to be able to reach out to your clinic. Is there anything I didn't ask you or that we didn't get into that you think, here's a nugget that I think is also really important? Anything else that we have forgotten?
Um, I guess one that I will say is I work in reproductive psychiatry, so I'm very much aware of the role of hormones and very thoughtful about that. I just want to emphasize that for women who are severely symptomatic, you need a multifactorial approach to treatment.
Mhm.
We can help figure out what's going on with your hormones and stabilize those, but your brain might have already started thinking in an abnormal way. And fixing that underlying cause doesn't always make you feel better. So don't feel like it's an either or. Sometimes it's a this and, right?
Mhm.
So we can help stabilize your hormones and you might also benefit from classical psychiatric treatment, whether that's therapy or medication.
Mhm.
And then everyone benefits from community.
Mhm. I love that. I love that. It's a great place to end. But I want to, now that I'm thinking of a final word,
Hmm.
something you said earlier, I wanted to highlight, which is there are many things that can create these changes postpartum,
Hmm.
even including your thyroid. So making
Hmm.
sure that you're getting the right blood work checked to
Hmm.
make sure that there isn't something that's really treatable that's creating a
Hmm.
lot of your symptoms, not making assumptions that this is
That's
just what
right.
happens with my hormones. So.
That's right. Yeah.
All
So
right, very good. Well, thank you again so much for your time and all of your wisdom and information. I'm sure so many people are going to benefit.
it's been a pleasure, Lori.
You take good care. Thanks
Take
again.
care. Bye.
Thank you for being here with me today. I'm happy we're on this journey together. I hope this conversation gave you something to think about, maybe a moment of pause, a little insight, or something you can carry into your own life. To stay connected, follow Becoming Real. Share it with someone who may also need it. And if you have a minute and you feel kind, please leave a review. It helps more people find the show. And if you want to go deeper than this podcast can take us on these and other topics, consider joining our community where the real conversation continues at the link in the show notes below. Until next time, this is Becoming Real.